My name is Carlos Collet. I'm an interventional cardiologist at the Cardiovascular Center Aalst in Belgium. The field of coronary physiology has evolved, and it was basically developed to answer the question if a lesion was significant or not significant. Now we have expanded the use of physiology using pressure pullbacks. And when you do these maneuvers of pressure pullbacks, you basically understand what is the pattern of coronary artery disease. And we have identified that there are two main patterns, one that we call diffuse disease, another one that is focal disease. And the response to PCI, to stenting, is different in cases of focal versus diffuse coronary artery disease. So the rationale of this study was to understand what were the outcomes, the procedural outcomes after PCI in focal versus diffuse coronary artery disease. So this was an investigator-initiated trial. We performed the study globally. Basically, we included patients in Asia, the US, and Europe. We included 1,000 patients. And the trial recruited stable patients with significant lesions based on fractional flow reserve less than 0.8 with intention to be treated with PCI. And in those patients, we carry out a physiological protocol that consisted on, first, measurement of distal point fractional flow reserve, second, a manual pullback maneuver with a calculation of a novel index called PPG, and after PCI, a new measurement of fractional flow reserve to understand what was the result of the PCI in terms of the improvement in blood flow. So what we found was that the pattern of coronary artery disease, as quantified by the PPG, predicted the result of the procedure in terms of the improvement in flow. In other words, patients with focal coronary artery disease, defined by the PPG close to 1, had a significant improvement in blood flow that was not observed in patients that had a low PPG or diffuse coronary artery disease, where even after stenting and a successful angiographic procedure, the flow remained suboptimal after the PCI. So in addition to predicting the result before the intervention, we also observed that patients with diffuse coronary artery disease have double the event rates related to the procedure itself. I'm referring to the fact that patients with diffuse coronary artery disease had a rate of periprocedural myocardial infarction that was significantly higher than patients with focal coronary artery disease. That can be translated into the fact that PCI is, one, more effective and is safer when performed in patients with focal coronary artery disease. Now, the big question that we have is, what to do with diffuse coronary artery disease? We know that we're very good at treating focal disease. Now, what to do with diffuse coronary artery disease? And the answer is, we don't know. But basically, with the advent of PPG as a tool that standardizes the definition of diffuse disease, we're now ready to go into a randomized clinical trial to test new treatment strategies for patients with low PPG or diffuse coronary artery disease. So the next step is a randomized clinical trial, basically using the PPG to define the need for PCI. So we're going to randomize patients, not based on the classical FFR, less than 0.8 or more than 0.8, but now we're going to use PPG to refine the indication of PCI and see whether that translates in improved clinical outcomes.